All right, welcome everybody. Thank you for joining us today for MVC's Rural Health Workgroup presentation. My name is Rachel. I'm one of the site engagement coordinators with MVC. It's my pleasure to be facilitating this workgroup for you today. Just a few housekeeping items to review. First, we do record these workgroups. These slides and recording will be shared with attendees following the workgroup. A little reminder to please make sure to mute your microphone throughout the workgroup presentation. That just helps reduce background noise. You are definitely welcome to unmute if you have a question or during the discussion time. And then just a reminder that if you have questions throughout the presentation, you are welcome to put them in the chat and we will address them depending on the presenter's preference, either throughout the presentation or at the end during our question and discussion time. A reminder for our P4P sites, we look forward to your active participation throughout the work group. And then also we will be sharing our post-work group survey at the end of the work group in our chat. So make sure that you stay to the end to get that link to fill that out for your P4P engagement point credit. Today's agenda includes a presentation on chronic kidney disease screening initiatives in rural health. And following that presentation, we will have a discussion, question and answer time. Today's presenters include Mary Wozniak and Jill Oesterle. Mary Wozniak is the Program Manager of the National Kidney Foundation's Health Systems Interventions Department with 16 years of experience in public health and program management. Mary focuses on optimizing CKD screening to improve patient care outcomes and ensuring health systems meet the evolving needs of their communities. Using her background in quality improvement and community healthcare, Mary leads the team's chronic kidney disease programs by educating healthcare professionals on kidney disease, improving processes, and promoting best practices within health systems to improve quality measures. Jill Oesterle serves as the Director of Provider Solutions at the Michigan Center for Rural Health, where she leads programs aimed at advancing operational efficiency, financial sustainability, and clinical quality improvement within Michigan's rural health clinics. She also manages the Michigan Rural Health Clinic Network, providing strategic direction and support for its initiatives. Jill has successfully directed several grant-funded projects focused on primary care innovation, including the Rural Health Clinic Quality Innovation Lab, Healthy Hearts for Michigan, the National Kidney Foundation CKD Awareness Initiative, and the enhancement of team-based cardiovascular care program. A certified rural health clinic professional and trained practice facilitator, Jill also brings practice expertise from her prior role as a rural health clinic practice manager. She's an active leader in the rural health community, serving on the executive board of the National Organization of State Offices of Rural Health and as a policy committee member for the National Association for Rural Health Clinics. All right, and with that, I will be handing off the presentation to Mary. So Mary's going to share her slides.
Hey, thanks for the introduction. Hi, everyone. It's so happy to be here with you today, especially for the opportunity to talk to you during March is Kidney Month and really highlighting the importance of early detection of chronic kidney disease. I work with the National Kidney Foundation of Michigan, and our mission is to both prevent kidney disease as well as improve the lives of people living with it. So today we are going to talk about CKD as a public health problem, kind of give you the why of why we're focused on this, and then get into some more specifics around the quality improvement project that we have conducted together with Michigan Center for Rural Health, as well as,
sorry, Mary.
Yes.
It looks like your presentation window flipped on you. If you
Okay.
go up to display settings
Yeah.
in there, it'll let you swap the windows.
Oh, presenter. Sorry about that. One
That's
second.
okay.
Let me try this
Just didn't
again.
want you to go too far with it like that.
I appreciate that. Okay.
Okay. Yeah, if you hit the presenter mode and then
Is it showing okay for you on that?
There you go.
yeah, now it is.
Okay. All right. Thanks. And then towards the end, we're going to go over a CKD toolkit designed specifically for rural health providers in Michigan, that we hope will be a great tool for you all to use as well. So just to kind of level set as to what chronic kidney disease is, it's the progressive loss of kidney function over time. So it defined as at least 3 months of declining kidney function or other impacts on kidney health that can lead to other health problems, such as heart attack, stroke, anemia, ultimately kidney failure and death. CKD can creep up on you silently, so you may be losing kidney function for many years without having symptoms. And that's why it's so important to know your kidney numbers. And there is no cure for chronic kidney disease, but we can slow progression down, particularly through early detection. There's many medications that have come out now in the last decade or so, as well as lifestyle changes. And end-stage renal disease, ESRD, that's the last stage of CKD when the kidneys can't function any longer on their own. And that requires a dialysis or a kidney transplant to survive. So low recognition of chronic kidney disease is a public health problem because not only is it associated with substantial morbidity and mortality, shortened life expectancy, but there's also excessive healthcare costs along with that. We know that about 36 million Americans have chronic kidney disease. That's 1 in 7 adults, but it is often undetected. So even up to 90% of people with CKD may not know that they have that, according to the CDC. It is the 9th leading cause of death, but also importantly, it contributes to heart disease, which is the #1 cause of death in the United States. For Medicare expenses, over $100 billion of Medicare expenses. That's almost 26% of the total costs is for Medicare beneficiaries who have diabetes as well as CKD. So I want to give you a little overview of CKD in Michigan. This is based on Medicaid claims data. Kind of gives you a sense of where the highest prevalence of CKD is in the state. So kind of that middle of the mitten, the thumb area, and Southeast Michigan. In particular, I noted here Clare, Roscommon, and Tuscola counties because that is where the rural health clinics are that we held the quality improvement work in. Keep in mind that this percent of 8.2% is likely an underestimate because we know that CKD is not being diagnosed as well as we would hope. So it is likely quite a bit higher than that. There is hopefully you all are familiar with the NCQA quality measure. This looks at kidney disease testing for people with diabetes. So in the Medicaid population, about a quarter of those with diabetes in 2022 were tested with an EGFR and a UACR. That's the 2 tests that go into that component. And then it was somewhat lower in Clare County and Tuscola County compared to the state average. Along with that Medicaid analysis that the National Kidney Foundation conducted, we also looked at kind of cost by stage of disease. So you can see quite a bit higher costs, of course, with stage 5 or end-stage kidney disease, as would be expected. But in total, that it was almost $4 billion spent in the state of Michigan on treating beneficiaries with chronic kidney disease. And the difference in cost is about 6 times higher than treating an individual who does not have CKD. These are the main risk factors for developing chronic kidney disease, the top 2 certainly being diabetes and hypertension. That accounts for about 64% of all the kidney failure cases in the United States, as well as older age, having a cardiovascular disease, and having family history of kidney disease as well. Chronic NSAID use, like ibuprofen, can also damage the kidneys over time. And people who have a history of acute kidney injury, so for example, if they were hospitalized, they're also at greater risk and should be followed up after that AKI event to check if their kidney damage is progressive or not. Um, so based on those risk factors we just looked at, it is important to screen patients who are at high risk of chronic kidney disease. And this is in line with the guidelines. We noted those there from KDIGO and KDOQI. CKD is diagnosed using these two tests that I had mentioned. The eGFR is the blood test that gives you insight into the overall kidney function. And the second is the albumin to creatinine ratio. And that provides insight into kidney damage, which might actually appear before the eGFR starts decreasing. So I would love to just take a moment and hear from many of you who might want to chime in about how are you or are you currently assessing patients for these risk factors and testing them for CKD? Does this kind of match your protocol? Are you testing people who have diabetes or other risk factors at this point? Just give a chance if you want to respond in the chat or unmute.
Hi, this is Kelly from Lake Huron Medical Center. I'm
Hi.
pretty new at this facility. I started in the fall in October. So I'm not quite sure. I do see that we are drawing EGFRs on people. And as a nurse of 23 or 4 years now, I can't remember, um, I've never really fully understood it. I was a case manager for a while. I have ER background. Looked more like I was setting people up for dialysis chairs. I looked more at the creatinine than anything, the BUN as well. Um, and of course, it had to be CKD5 to get them covered in the chair. Otherwise, it was considered acute, which is a whole nother world of issues. Yeah, so I don't know if maybe at the end we have time to explain the EGFR a little bit more. That would help me.
Sure. Yeah, I can mention that real quick. So the eGFR generally is calculated based on the serum creatinine. It also takes into account age and body size. In the past, that it also had a component in the calculation for race, so it would give you a different output for someone who's Black versus non-Black. That racial component has been taken out at this point. Really, it's no longer recommended to because race is really not a biological construct, it's really a social construct. And that was creating some discrepancies and disparities for the Black population in terms of access to getting on dialysis or getting on the transplant list. So, and to, yeah, so I guess the short answer would be that the eGFR is based on that serum creatinine measure. And this is really just the basic screening test. It's not a whole renal panel. The renal panel you may wish to do if someone is already diagnosed with kidney disease, and you're kind of tracking how that goes over time. I hope that's helpful. I'm not a clinician, so I don't want to get too much into the testing, but that's kind of the basic overview.
Thank you, it is. And now thinking back, reviewing those charts when I was a case manager at my last job, I do remember them being split between having a GFR for African American versus non-African American. So yeah, that's helpful. Thank you.
Okay, thanks, Kelly. Well, just chime in if you do have other questions as we go along, or if you want to add anything. I'm going to switch gears now and talk a little bit about our Learning Collaborative initiative that we did in 2024. We partnered with 4 different rural health clinics, and of course, the Michigan Center for Rural Health has been an amazing partner on this project. And really the goal of this is to increase the awareness around early detection and management of chronic kidney disease. Particularly, we were focused on Medicaid eligible populations, but really any population can benefit from this. And this consisted not only of clinical education for the provider and the care team, but promoting referrals to lifestyle change programs, and providing support and guidance on how to really update clinical workflows and incorporate this kind of screening into their day-to-day. So the strategies that we used in this learning collaborative included a baseline assessment. So there's a data assessment that goes into kind of identifying the prevalence of CKD, diagnosed CKD in your population, the current CKD screening rates, both for people with diabetes and people with hypertension. We also delivered 1 hour tailored training. This was from our staff as well as some nephrologists that we had on our scientific advisory board provided an overview on diagnosis and staging of kidney disease that's including using the heat map technology and workflow options to incorporate this into their workflow. And then preventing and managing CKD progression from the pharmacy perspective. And then also, of course, touching on lifestyle and how nutrition can play into preventing or managing chronic kidney disease. These are really some of the outcomes, I guess, that came out of this is that the protocols and policies got updated. Jill's going to share a lot more detail with you on that. And then when possible, updating the clinical decision tools within the EHR. I know not every, rural health clinic has the autonomy to really update their own EHR. So it really depended on a case-by-case basis around that. But really empowering the healthcare team with actionable recommendations and a lot of patient education materials that were developed specifically to educate patients on their kidney disease health, on their kidney health. Okay, I am going to take a pause for a moment if there's any questions, and then I will turn it over to Jill. So I'll stop sharing, Jill, if you want to share. She's going to go into more depth around the interventions of each clinic and then this great toolkit that we can share out with everyone. Thank you.
I have to unmute myself. Thank you, Mary. It was a fantastic partnership. We were able to partner with the National Kidney Foundation and enroll 4 of our certified rural health clinics, which actually matches up with some of the names that are on the call today. Although you're not part of the rural health clinic, you're part of the health system that the rural health clinics belong to. So I do see a number of familiar names that participate in the Michigan quality network for our critical access hospitals. So pleased to share the outpatient side of things and the work that happened. So as Mary said, we had a great partnership. We did a lot of targeted work with the clinics. I first just want to highlight just some of the lessons learned. The partnership with the clinics was a great opportunity for us to really focus in on chronic kidney disease. It's something that's relatively newer in terms of the clinics actually tracking this type of measure and doing work in this space. First and foremost, one of the biggest lessons learned was, and you probably all know this because you guys work with data, is there was some extra time needed to kind of figure out that baseline data component. Our EHRs oftentimes are a wonderful tool as we document patient information, but in terms of getting information out of our EHRs, that can be sometimes challenging. And that was certainly the case with the 4 clinics that we worked with. But really identifying some of those data and quality challenges and then finding out some of those solutions or some of those rectifying some of those barriers were important keys to our success. We had some clinic champions that helped lead the project through the 6 months that we did work. But we also had provider champions that came on board with this project as well. And that was super important to have some of those provider champions really get engaged with the work that we did. We also engaged some of the laboratory staff to help understand the 2 lab tests that needed to be done and how the profile was set up in the EHR. Those were all things that we learned that were key components of some of the success that we had. Let me move my screen here. Additional lessons learned that we had were, coaching some of that frontline staff and the primary care providers, really giving them the opportunity to ask questions in some of our collaborative work that we did. We definitely had some flexibility. Each clinic did a little bit different, knowing what and how their team worked best around some of the challenges and some of the resources that we provided. We did do some data collection. I'm really excited to share some of the work that we did, and I'll coin Mary As we look at the data, I asked how we did. We were so excited to understand how they did in terms of the overall project. And I believe her words were, quote, they knocked it out of the park. So that was super exciting to hear that. And I'll share some of that data. But these were just some of the lessons learned. We did understand that this is an extra lift for the clinic. So we were able to provide some small stipends that help support the cost of additional reporting requirements and additional time within this. But ultimately, there was a lot of great things that happened. Some order sets were created for the diabetes, some blood pressure control protocols, and streamlined processes were really our focus. I think the highlight for me in terms of lessons learned is that quality improvement requires time and sustained focus. And all of you who already work in that quality space know this. But it's an ongoing effort. It's not a one and done. We continue to support the clinics beyond this project timeframe. I have some of the clinics reach out to me currently to be able to help refine their processes and continue to grow in this space. So we know quality improvement is an ongoing process, and we all work very diligently at it. The participating clinics, some of their next steps is that they're working with the referral process to the PATH program, which I'll go into in just a minute. They continue to identify the team member to lead the PATH program. That's something that McLaren is doing very diligently and utilizing that resource. They're evaluating at the end of the calendar year to identify the final improvements made through that education and awareness of the CKD. Aspire, which is over in the thumb, they worked with the Aspire lab to modify the ranges for their UACR and their EGFR. They continue to screen their patients diagnosed with hypertension and diabetes, of course, those two large risk factors for chronic kidney disease, and then streamlining their processes to some of those, again, NKFM self-management programs. So those are all the lessons learned and kind of that wrap up. I feel like I missed some slides. I did. Okay. No wonder I'm feeling behind here. I apologize. So the two systems, I should have had this first. We worked with Aspire Rural Health System. They're out of Cass City. They had two clinics that participated with us, and that was Cass City Family Practice and Cass City Medical Center Practice. Both of those practices had provider champions as well as quality improvement champions and the practice manager. They all participated. And as I already shared in the lessons learned, they really did some diligent work around changing up how their lab profile existed in their EMR. The other practice was McLaren, and that was the St. Helen McLaren Primary Care and the Clare McLaren Central practice. It was great because within this opportunity, we were able to go out and do site visits and actually step foot in the clinics and really engage the providers and the entire staff, which I think was really essential. It really kind of allowed us to see it from their view. And also see how committed they were to the project. I'm going to share a quick video here in a minute, but it was amazing how engaged that the providers got when we came to their level and engaged them in the process. I think the biggest lesson learned for McLaren is the data pull. Knowing that they're a large health system, they still had challenges around pulling the data and getting the information we needed so we could effectively track some of the changes that they were seeing. So here's the data. As I mentioned, Mary indicating that, they knocked it out of the park. You can see for clinic, I'm going to pull this over. For clinic A, they started at 11.5% in terms of screening rates of those individuals who had diabetes. They ended at 42.2%. Clinic B was starting at 33.2 and ended at 35.4%, which these are huge increases. And again, Clinic C started at 8.6, ended at 41.4. And Clinic D, not as big of a range, but still a huge increase, 26.2% to 46.6%. Those were all individuals had those screening rates in diabetes. And you can see the huge increase in terms of their baseline to their final. And then also with regards to the other risk factor, of course, with CKD is hypertension. Again, you can see, I won't read through the numbers, but you can see the huge increases of change within that baseline to that final screening rate, which I thought was fantastic. Additionally, in terms of CKD diagnosis, again, diagnosing based on their baseline, it started at 5.2% to 6.6%. These were smaller increases, but definitely still noticeable. In terms of Clinic B, 3.9 to 4.1, and then here you see some of those bigger numbers. Clinic C and D had huge increases in terms of the average increase in CKD diagnosis. Which really helped us understand that, you know, this project was working and the changes and interventions that took place within the clinic were working. So some of the successes, we definitely know that NKFM and MCRH adapted to the training to each and every clinic. We knew that we had to work with them individually and meet them where they were at within the process. I think that was a huge success we were able to do. Also, the clinic teams had the opportunity to share with each other. I think, again, having that collaborative approach really made a huge difference in the work that we did. So within the collaborative structure, not only did we get together all 4 clinics, the providers, and the support staff on a call once a month to go through kind of the education platform and also allow them to communicate with one another. But then we met with them separately on a one-to-one month call as well to help them work through some of their processes individually. We did the lessons learned. One of the other things that we did as part of this process that we recognize, and I think all of you recognize that if you work in rural, some of the challenges around resources for your providers and resources for your staff. We recognize that oftentimes there isn't a department within your hospital or within your clinic that supports education, that those resources are small. So we took some of the funding that we received from this project and create a CKD toolkit for rural providers. This lives on our website, and we worked very diligently alongside NKFM, as well as some of the providers that participated in this, to really highlight and curate some of the resources that they found most valuable during this process. And now we're able to sustain that on our website and then keep that up to date. So I'm just going to walk you through that very briefly. Starting with some of the rural specific solutions and support, we made sure that we covered these 4 main topics: educational materials and training for the providers, patient education and engagement. We know that the providers and the staff can only do so much, that there's definitely some accountability with the patients, but getting them engaged and educated was really important part of this. CKD management, the workflow. We made sure that we included information there and then really highlighted some of those schools or screening tools and resources. So just to dive in just a little bit, this by far, this little tool here, how well are your kidneys working, was by far the most favorite tool of the providers that participated within the collaborative. And I think I selected the video to show you the provider talking about this. And this was just an overwhelming favorite tool that they use to speak to their patients with regards to the status and how well their kidneys are working. But you can see all the hyperlinked pieces here of the different tools that are included in this toolkit that specifically are education for the providers. Here's the video, and hopefully I'll be able to play this and it'll work. And it's not, so I'm going to pause for just a minute and pull this over here. You guys have to let me know if this is not working appropriately. Can you guys see the video screen?
Yeah, can you expand it? I don't know if we can hear it.
Yep. Let me expand it and also make it just a little bit louder because this is an awesome video. So part of the collaborative work that we did, just to give a little bit of background of this, is we really wanted to be able to highlight the work that happened And who better to highlight that work with than the providers that participated within the project. So we did 1-minute videos with each of the providers that participated, and specifically asked them to highlight a part of the collaborative and a part of the work that they really enjoyed and felt was meaningful and impactful to them. So this particular provider, Rachel Van Wormer, is from one of the McLaren clinics, I believe the St. Helen Clinic, if I remember correctly. And these also live on our website, so I'll play that for all of you.
Doesn't
No,
sound
we
like,
can't, there's no audio.
yeah.
There's no audio. Of course there isn't. I had a feeling that might be the problem. I may not be able to share it. It was a brilliant idea while I had it.
We could
I
put
will
that
make,
link in the chat if you like.
that would be great. Thank
Yeah.
you.
You can also send it in the follow-up email that folks will get after the meeting, after the work group.
Perfect. Thank you. I appreciate that. I was hoping that it'd work. And I know that's always a tricky thing on this. And I know there's a way to do it probably, but these are the videos that were out there. Of course, my colleague and partner in crime at the center convinced me to doing one of the videos, which ended up turning out okay. It's nothing that no one really wants to do this, but I did. But it really was a wonderful opportunity to partner with the National Kidney Foundation of Michigan and bring these resources to our certified rural health clinics and the folks that we support. So additionally in the toolkit, again, some interactive tools. This particular tool is Are You the 33%? It allows them to take a quiz and send this to the patients so the patients can take their quiz. It talks about the kidney pathways. There's some absolutely phenomenal resources that National Kidney Foundation of Michigan, they make available to all of our patients across the state. But more importantly, with the folks that we've worked with of getting this kind of tool in the hands of our patients. So here's a little bit more about the PATH programs. There's a diabetes path, a kidney path, a high blood pressure pathway, a chronic disease. Those are all pathways. Mary, do you want to give a little bit of information about the path? I know the Kidney Foundation is the one that runs this, and you can probably do it a little bit more justice.
Little synopsis. These are evidence-based programs that we make available. Most of them are virtual, but we do have some available in near the Grand Rapids area in Southeast Michigan. But the goal of these is that a trained peer will lead the program for 6 to 8 weeks. And participants really learn self-management strategies throughout the program. In particular, some of them, as you can see, focus on a particular chronic disease. So diabetes, managing your blood sugars and sick days, whereas Kidney Path will get more into the different options for the difference between dialysis and transplant. And they also have a nice panel of professionals who come onto Kidney Path to answer specific questions. But in general, all of these programs have a strong focus on self-management and helping people to set goals for themselves. It's in no way replacing medical information, from the doctor's office. We always refer back for any particular specific medical questions, but really it's to empower people to take control of their chronic condition. So it is free and it's available. We welcome, self-referrals. We welcome referrals from providers. If you are interested in more information, I would love to chat with you. So please do send me a message. Thank you.
This particular part of the work that we did, again, was another fan favorite from the provider's perspective. We know patients in rural oftentimes have transportation issues or issues with accessing resource, and this was a really good virtual fit for them. They do a lot of virtual work as well, and it's something that the patients can really take some ownership over. So that was, again, another fan favorite from our providers who participated. Again, another part of the toolkit is we really focused in on some of those workflow and alignments with the national standards. So we created links to link the providers directly to that. We know all of our clinics and our hospitals, they operate on policies and procedures. So in terms of formalizing things within the clinic, we made sure to include a CKD management policy that they could adopt within the clinic. We shared this video here is a really great video on healthy huddles, of course, making sure huddles are happening within your clinic space to target those patients with some of those chronic illnesses that need extra attention during the day. And then we created a PDSA plan. So for those clinics that wanted to take the next step within the Plan, Do, Study Act, we created a template of work that was specific to the CKD PDSA plan. And again, all of this lives on our website. Here was some additional screening tools and resources. There's some really phenomenal apps that support the CKD screening process that the providers can download. Of course, we know our mobile apps are kind of that new wave of technology. Just a quick calculator for the EGFR, that was something that the providers could use on their desktops. And then the kidney health evaluation for diabetes or for patients with diabetes. All of these were tools that we curated and specifically put a link to so the providers can easily access those. So here are the references, again, that we had put together based on all of the work that we did. And that's all I had. Questions?
Thanks, Jill. It looks like we do have a question in the chat from Jonathan.
No, anybody can use this toolkit. We curated it specifically for the rural providers just because they do tend to have a shorter amount of resources. But all of these are evidence-based practices. Most of these came from the National Kidney Foundation of Michigan, but because of our recognition within the rural space and our rural stakeholders, we know that oftentimes they come to us for this information, but anybody can use this toolkit. And we plan to continue to keep it updated and partner with the National Kidney Foundation of Michigan to keep everything relevant. And as things change, we'll change.
Awesome, thank you. Any other questions? All right, so I have a question for our attendees. Kind of a general question to kind of maybe stimulate a little bit more discussion. I was wondering if maybe if your site doesn't have a chronic kidney disease screening tool in particular, if you do have a screening tool that's utilized at your site, how do you notice like how it impacts patient care, if there's like pros or cons, and then also any input on how it maybe impacts the providers using the screening tool, and if there's any pros or cons with that.
And I'll just real quick add in here that if you do have toolkits that you want to share, we are working on different ways of being able to get those out to folks, but always keep an eye out for the Workgroup blogs because we usually try to include some information on there about that. Thanks, Emily. Just put the link in the chat there too for those that would like to access the toolkit.
All right. Okay, well, it seems like maybe we don't have any burning questions. Oh, here we go. Hold on. So from Stacy, she's familiar with the HADIS measures for CKD, but is there a HADIS specific measure for hypertension?
I can take that question. Yeah, at this time, there is no HEDIS specific measure to test people with hypertension for CKD. I do believe that's in discussion right now with NCQA, but it has not happened just yet. But it is in line with the existing guidelines, both from the AHA as well as the KDIGO. So thank you so much, Stacy, for that question.
And just a quick addition to that. So with the certified rural health clinics, I know many of you have some within your health organizations. We have done a lot of work in the hypertension space as well. We did a project called Healthy Hearts for Michigan, We worked with the rural practices. We went out to those rural practices and provided resources on accurate blood pressure measurement, self-measured blood pressure programs, your smoking cessation programs. So those are all resources that we have as well. So if you have a clinic attached to your health system that you represent, again, feel free to send them over to our website. There is some information on hypertension as well, or they can always reach out to me if they need any assistance on interventions or workflow processes related to hypertension.
Awesome. Thanks, Jill. And just so everyone's aware, I will be sending a follow-up email, and then I will link Jill and Mary's emails in that. So if you do have any follow-up questions, you'll be able to send them over via email. Okay. I'm not seeing any more questions popping up. So I think we're going to move on to our MVC information here. So we have some upcoming work groups. Next will be on March 20th. We have our post-discharge follow-up work group on the MVC website. So you guys will have that information shortly. And then we have, after that, our first pre-op testing work group on April 8th, and then our health and action work group on April 24th. And then just a reminder, all of our work groups occur virtually from 12 to 1 o'clock via Zoom. So we have some upcoming events. Reminder that site coordinators, please complete your MVC contact update form by March 18th. You should have received an email for that. Please notify us if you did not receive that email, and we'll be happy to send that over. Next, we have April 2nd, our first virtual networking event of the year. That will be from 12 p.m. to 1:30 p.m. Registration will open for that on March 18th, so keep an eye open for that coming through. And then our big spring collaborative wide meeting is on May 9th. It's a Friday. It will be hosted at the H Hotel in Midland, Michigan this year again. And registration for that will be opening later this month, so stay tuned for that, that information to come through via email as well. And just a reminder, we are looking for presenters for our 2025 work groups, the collaborative wide meetings, and more. So you're welcome to submit a presentation proposal through a form. The link to the form will be shared in the email. It'll also be in the slides that are sent with that email as well. All right. Emily, if you could share the link, the post-work group survey will be in the chat now. So if you are attending for P4P engagement points, please fill out that form. And reminder to fill out one form for one site that you are attending for. And otherwise, everyone have a great rest of your day.